Morning, good afternoon, and good evening to all our friends and colleagues from different continents. I'm Dr. N.Y. Chen, President of Hong Kong College of Cardiology. My warmest welcome to the Hong Kong Complex Cardiovascular Intervention 2021 on my most thrilling case in the past 3 years. It is an important strategic direction of Hong Kong College of Cardiology to collaborate and connect with cardiovascular societies and professionals from all parts of the world so that professional education can be achieved effectively and patient care can be improved. The Cardiovascular Intervention Chapter of Hong Kong College of Cardiology was formed amidst the COVID-19 pandemic and in the era of virtual meeting. Despite the unprecedented challenge put forward by COVID-19 pandemic, professional education has evolved and a more efficient virtual platform has been well developed. Having said that, I eagerly hope that with the Fight Back by Vaccination program, we can both connect physically and virtually in the next Hong Kong CCI meeting. With that, I wish you to have an enjoyable and fruitful learning experience in our exciting program today. Andy, to you. You're muted.
Thanks, NY. So today we are really honored to have a very experienced moderator and panelists to join our conference. So it's my pleasure to introduce my co-moderators, Dr. Rosanna Miran. She's a professor in cardiovascular clinical research and outcomes, professor of medicine, cardiology, and population health science and policy, Icahn School of Medicine and Mount Sinai. And Professor Duk-Woo Park from Korea, and he's a professor of interventional cardiology, Asan Medical Center, University of Asan Asan College of Medicine. Professor Marco Roffi from Switzerland, and he's a professor of cardiology, vice chairman of cardiology, and director of interventional cardiology unit, University Hospital of Geneva. So our experienced panelists include Dr. William C.K. Chen from Hong Kong. He's the current president of Hong Kong Society of Transcatheter Endovascular Therapeutics. And our president, Dr. Ngai-Yin Chen, and Dr. Gary Singhim Chen is the president of the Hong Kong Society of Congenital and Structural Heart Disease. And Dr. Yip-Man Fai, he's the consultant of the Central Hospital Conde de Janeiro and Macau. And Dr. Christopher Jensen from Germany, and he's associate professor of medicine, medical director of a Born company. Dr. David Kettles from South Africa, he's a cardiologist in St. Dominic's Hospital, and he's the immediate past president of the South African Society for Cardiovascular Intervention. Dr. Simon Lam from Hong Kong, he's an associate consultant of the Queen Mary Hospital. Simon is also the course director of this important conference. Dr. Lam Ho is a consultant of director and director of Lab Human Hospital. Lam Ho is also the course director of this course. Dr. Sidney Lo from Australia, he's the director of Cardiac Labs, Liverpool Hospital, Sydney. And Professor Tse-Min Lo from Taiwan is a professor of medicine, National Yanming University, Chief of Healthcare Center, Taipei Veterans General Hospital, Taipei. And Dr. Paul Ong from Singapore, he's a senior consultant cardiologist, Heart Specialist International. And Dr. Lucio Padilla from Argentina, he's the program director of CTO and complex PCI of ICBA. Professor Santoso from Indonesia is the cardiologist at Mitral Hospital. He also received a lot of awards, including the award for his contribution to the field of the interventional cardiology, Indian Life India. And Dr. Rahul Sharma from USA is the director of structural interventions, Stanford Healthcare, clinical assistant professor of medicine at Stanford University. And Dr. Tam Liwa from Hong Kong, he's the chairman of the Hong Kong Public Hospital Cardiologists Association. And Professor Jack Tang from Singapore, he's the director, deputy head of cardiology and director of coronary care unit, National Heart Center Singapore. And he's also the president of the Asia Pacific Society of Cardiology. And thanks, Professor Cheung, for making this event also on live on the APSC Facebook Live tonight as well. And Professor Brian Yan from Hong Kong, he's the head of Division of Cardiology, the Chinese University of Hong Kong. And Dr. Chi Chao from China, he's the Associate Chief Physician, Chinese Academy of Medical Science, National Center for Cardiovascular Disease, Fuwai Hospital. Oh, okay, so may I take this opportunity to invite Dr. Rosanna Miran to introduce our first speaker. So Rosanna, please.
Good morning, good afternoon, good evening to all of you. And what an incredible honor for me to be part of this. I want to thank the Hong Kong College of Cardiology for inviting me to this Hong Kong Complex Cardiovascular Intervention 2021, my most thrilling case in the past 3 years. I can't wait to see these cases, and this is the second virtual meeting, and I am really, really pleased and honored to be moderating today, and also to be introducing our first speaker, Dr. Shozo Ishihara from Japan, Osaka, Japan. He's the Vice Director of the Hospital Manager of Cardiology Department and Vice Director of the Hospital Manager of the Cardiology Department at Mimihara General Hospital in Osaka. And we're thrilled to hear about your most thrilling case in the past 3 years. Dr. Shozo Ishihara.
Thank you for Chairperson. I'm so great. It's a great honor to join this great conference, and also I'm so happy to be your first speaker. Can you see my slide? It's okay. Yes. So this is my most thrilling case in these 3 years, and also this is very serious complication case, but I think this is very, very educational for all PCI doctors. So the title is Severe Epicardial Channel Perforation bailed out with various embolization during retrograde CTO PCI. So the patient was 66 years old male, and he had stable angina. And she findings showed proximal LED CTO lesion, and so with collaterals from RCA, acute marginal branch, and also from circumflex. His coronary risk factors were diabetes, dyslipidemia, and also smoking. So ECG showed poor R progression in chest lead, and also his renal function was relatively preserved. And echocardiography showed low ejection fraction, but his LAD territory was still viable. And this is the first CH image. We can see the total occlusion at proximal LAD, like this, here. And also we can see the good collateral from distal circumflex. This is an epicardial channel, like this. And also this is a RC image. We can also see the good collateral flow from acute marginal flow, branch like this, direct connection via apex to distal LAD like this. So this is the system and strategy for this LAD situation. So we choose a bilateral approach, and antegrade guiding was 8 French from femoral artery, and also retrograde guiding catheter is 7 French from radial artery, EBU, and also amplex left one. And strategy was, this case was not in our hospital, so other hospital's case. So we judged this case should be performed by local doctor. So so it means CTO proctorship. So he tried to his best, and if it is difficult, so operator should be changed for me. And so he chose primary retrograde approach, first approach from RCA epicardial channel, and if it was difficult, he moved to circumflex channel, and so next option is septal stopping. So this is the tip injection from right collateral channel, and it means so acute marginal branch. So there is a strong bending point, but the other part are almost straight, and it looks not so difficult like this. So this was a Caravelle microcatheter. And he started retrograde approach, so with SO03 guide wire. So he started the channel negotiation like this. And so the wire moves very nice course like this. So after advancing guide wire, but microcatheter is a little bit difficult to pass the so strong bending point around here. And after pushing microcatheter, severe perforation was revealed like this. So it was so terrible situation. So this was epicardial channel and relatively very good coronary flow, so that it will very serious situation. So that I advised him to perform prolonged balloon occlusion. This was a 2.0 millimeter balloon. But in this point, he gave up to continue by himself and also change operator from the local doctor to me. And in this point, check the left coronary, so that of course we can see the collateral from flow from circumflex, and also from RCA. So bleeding was stopped, but from circumflex still we can see still bleeding like this, because this is a so bilateral flow. So in this point, I started retrograde approach from circumflex channel like this, and we can see good flow, and also started with Caravelle microcatheter and also SO03 guide wire. And channel negotiation was relatively easy, but yeah, in some bending part, wire somehow stuck. But fortunately, the SO03 guide wire and also Caravelle microcatheter passed this epicardial channel like this. And fortunately, wire was advanced into distal LAD like this. And check with the CTO situation from retrograde tip injection and also antegrade guiding injection like this. So relatively, we can see the CTO lesion is still long, so that I started retrograde wiring first. And with Miracle 3 wire and also XTA wire couldn't advance into CTO region, so that changed to Gladius wire. This is also from Asahi, and so very slippery coating, and also tip load is 3 gram. This wire fortunately advanced into CTO, but direct cross is relatively dangerous because this is just proximal LAD region. So that I started antegrade approach with Corsair and also Gaia 2. And antegrade wire also advanced with the information of retrograde wire. This is a good roadmap, so that 2 guide wire is very near situation. And after checking IVAS, I performed reverse cut with 2 O balloon. From antegrade open up with 2 O balloon. So fortunately, retrograde wire passed the CTO part, but and also the wire could advance into antegrade guiding catheter. But unfortunately, Caravelle microcatheter couldn't reach antegrade guiding catheter because this guiding catheter is long one. So microcatheter length is not enough. So that I advanced additional guiding catheter because antegrade guiding and retrograde from circumflex two microcatheter, 2 wires are in guiding catheter. So that I add one more guiding catheter, 7 French guiding catheter from opposite side of radial artery. So fortunately, I could insert guide extension catheter. If I use only one guiding catheter, it was difficult to advance guide extension. But so we can see 3 guiding catheter like this. So fortunately, retrograde microcatheter could reach to guide extension catheter, and after that, externalization was achieved. And in this point, I checked retrograde injection, but retrograde injection from RCA, but unfortunately, still bleeding like this. In this point, blood pressure dropped down, and we should perform emergent pericardial synthesis like this. So after synthesis, blood pressure was preserved, and so patient was stable. So that we perform continue CTO procedure, and so still occlude with dual balloon, and after externalization, antegrade balloon open up to O balloon, and also sized up to 3O balloon. Put the stent immediately for mid-LAD, and also tip injection from antegrade microcatheter. This was fine cross. So we can see this is a tip of fine cross. So we can see still bleeding from RCA side. Bleeding was blocked with balloon catheter, but so retrogradely coronary flow will easily make severe bleeding. So that I put the coil like this. So from LAD side, so antegradely I put the 2 coils. So deliver through fine cross like this, and this is the second coil. We can see the coil was delivered from fine cross like this, and 2 coils were delivered like this, and put the stent from left main to LAD. And after putting the 2 stents from guiding catheter injection, still we can see still bleeding even after put 2 coils. So that in this point, maybe RCA flow should be blocked, so that we put 2 coils from RCA side like this. So totally 4 coils from RCA and also from antegrade from LAD side. So 4 coils are deployed, but even 2 coils, after 2 coils from RCA side, still bleeding like this. So that we discussed which is better, to put more cores and coils, or to put another material. So in this point, we can get the thrombus from puncture needle. Like this, there's a puncture needle. We can, as you know, we can get the thrombus from puncture needle, so that we inject from a microcatheter. After thrombus embolization, fortunately, hemostasis was achieved. Maybe thrombus with maybe somehow mixed with core, and so it made good hemostasis. And also from LAD side, we should put something, but already thrombus was used, so we have no thrombus. So that after thrombus embolization, but from LAD side still bleeding, we can see like this. So that from LAD side, I decided fat tissue embolization. Maybe you know fat tissue is easily get from femoral puncture site. Maybe around here, so from puncture side, we can cut by the small cutter. It is inside, it is in, we can get with cis dilator. So after taking fat tissue and after injecting fat tissue, hemostasis observed like this. We can see this may be a thrombus, and it is maybe around the coils, so it makes good hemostasis. So complete hemostasis from right side and also from left side was achieved. So this is a final angio. We can get the good revascularization for LAD-CTO, and also we can get complete hemostasis. So this is a case summary, 6 years old male, and the procedure time is around 6 hours, too long procedure. And fluoroscopy relatively high, but contrast was not so high, 150 milliliter, because we performed retrograde approach. So chip injection was effectively used. And embolization materials are 4 coils and thrombus and fat tissue. This is my first case of using all kind of embolization materials. So pericardial drain was retrieved next day, and so discharged after 1 week. So his condition was very nice. So talking about hemostasis of channel perforation, the important point is detecting the bleeding site is very important. So maybe using microcatheter tip injection is very effective. And also, if the perforation or bleeding is small, we can choose the microcatheter wedging, or sometimes we can use negative pressure with microcatheter. And also, as you know, prolonged balloon inflation is effective. And also, so hemostatic stability is very important. So we should prepare for pericardial stentation. And we should know any kind of embolization materials, coils, thrombus, and fat tissue are very important. And if it happens in retrograde, especially epicardial channel, bilateral approach. So it means bilateral embolization should be considered. So as you know, so this kind of coil is very, very important. But if doctor don't have so much experience, we should so prepare, or we should make training for using coils. This is the last slide. Detector bleeding site immediately occlude by balloon or microcatheter, hemodynamic stabilization, and prepare for pericardial stentation, and get used to various embolization. These are very important for effective so hemostasis for channel perforation. Thank you for your attention.
Thank you, Dr. Ishihara. We have 7 minutes for a discussion, and I'd like to open this up. This obviously was truly a nightmare case, 6 hours. And I think what happened here, you had what was, I think, life-saving here for this patient was your ability to have those two, to come at it at both sides, both from the antegrade, from the LAD, as well as from retrograde, with the use of coils. I must say I've never used fat embolization, nor have I used thrombus injection into a bleeding site. I wondered if we can open this up to questions, but also my first question to you is, what do you do in a case like this where you need, you have all these catheters in, you're worried about thrombus formation across everything, and the patient is bleeding. So are you keeping that patient still fully anticoagulated with heparin? Do you always use heparin? Do you stop the heparin? And how concerned are you with placing these coils in the distal bed of the site where you're actually performing a CTO? Did this patient fare well after all of this? So tough questions, but I think this might be good to start the discussion.
Yes, thank you for nice and also very, very important question. So anticoagulation is very important and very serious concern during the PCI, so with bleeding complication. For this case, if we can get enough embolization, maybe so anticoagulation is enough strong, but maybe hemostasis might be achieved, so that we continue giving heparin. Of course, so we should check the ACT, or maybe ACT should be around 300 because we use retrograde approach. Many guide wires, many microcatheters, and also 2 or 3 guiding catheters. So anticoagulation is very important, and we should continue giving heparin. But the most important is to reduce the blood pressure for the perforation site. So if the giving pressure for perforation site is reduced, so we can get hemostasis. It's important. So if the perforation site is difficult to make thrombosis, the embolization. For example, mid-LAD, if perforation occurred, at that time, it is difficult to embolize mid-LAD. But this part is easily, this part is okay to make embolization, so that I could continue anticoagulation. And if we reduce anticoagulation at that time, we should consider clot, so that we should flush guiding catheter with saline, or we should retrieve any other not needed devices, or such kind of
fantastic.
concerns.
I mean, you have so you're telling us that you would keep the anticoagulation at a low level. You're working towards embolization. I'd love to hear what Professor Marco Roffi. We have so many wonderful, talented panelists here. Professor Roffi, and maybe we can also ask Professor Santoso, anyone who wants to, Santoso, if you guys want to make some comments on this case. We just have a couple of minutes.
Thanks, Roxana. And it was a great case. And I was admirative of you continuing the CTO. My question is, there were bleeding, let's see, fed from both sides. So from the collateral from the right and collateral from the marginal. So obviously you had to coil both sides. The decision to continue CTO while ongoing bleeding, actually, was this because you were concerned that the LAD territory would have been in danger, for example, septal collaterals may have not been sufficient? Or why will you continue on your procedure before taking care of the bleeding?
It's also very important point. So maybe this LAD was mainly fulfilled from right collateral and from circumflex collateral. So that after balloon blockade from right side, and also if I perform the retrograde from circumflex, at that time maybe LAD territory have no collateral flow, so it makes patient condition more worse. So that it was of course, so maybe cardiac tamponade was happened before, but after retrograde procedure, maybe patient blood pressure decreased at that time. So we consider quit the procedure or continue procedure, but get hemostasis of serious population is more important than avoiding the ischemia. So that I continue. But so maybe it was many choices, so I should choose which is better. So so maybe if you have some suggestion, it is happy to hear.
That's great. We have a question in the audience, and please send in your questions. This is why we're here. And then we'll get to Paul Ong, who wants to ask a question. Should you have just tried the septals? This is one of the questions. Did you, when you see something like this happening, should you have tried, would it have been safer to go with the septal channels first when you saw that kind of a coiling bend in the apex where you were really going very far and then your catheter didn't reach in the end anyway? What was your, what are your thoughts there?
So thank you for the question. So maybe septal collateral is also one choice, but pre-angiography showed very poor septal connection. So because maybe from RC and from circumflex flow is so much so large, so that I wonder I could pass the septal channel or not. I couldn't at that time decided. So and so in my feeling, circumflex might be very easy, and so CTO so connection is not so difficult for me. So that I choose from circumflex.
No, that's great. That's fantastic. We just have. I'm just going to let Dr. Ong go, and then there was chat in there about thrombin, how it could be dangerous, and I probably agree with that. Dr. Ong, your last question, very short answer, please, because we have a lot to do today.
Yes.
I only have a very short comment to make.
So
apart from saying this is a fantastic case and learned a lot, but I sometimes find that I learned this from the Hong Kong STEM group, that doing very complex case with risk of perforation, one tips that I've learned is maybe before you heparinize the patient, just draw up 10 mils of blood and have it on the trolley and leave it there. And if something like this happened, you always have thrombus to use to occlude any perforation. And if nothing else happened, you wasted 10 mils of blood, no harm done. That's all I have to say.
So muted, Mehran muted.
Sorry,
okay. That's
fantastic. Thank you so much, Dr. Ishihara. That was really a fantastic case. And now we go to my dear colleague, Professor Duk-Woo Park, who's Professor of Interventional Cardiology at the Asan Medical Center, University of Ulsan College of Medicine. He's currently the new deputy editor of JACC Asia, and I'm so pleased to see him. He's tremendous, and of course, one of our moderators. He's so well known to all of us. Professor Park, we can't wait to see your most difficult case in the last 3 years. Professor Park.
Okay, thank you, Mehran. So I'm going to share the most thrilling case in the past 3 years. This is a sort of complex application, the PCI region. I'm guessing the one of the audience experienced a similar case. I'm going to move to my case. This is my disclosure. So look briefly, the brief background, the 51-year-old male with stable angina, and he was current heavy smoker, 25-year history. He has no diabetic and hypertension, and just current smoking. So looking at the ECG was absolutely normal. Chest X-ray was normal. The heart, there is no cardiomegaly and no pleural effusion. Looking at the transthoracic echocardiography and the ejection fraction, it's a 64, and the normal LV size, and the systolic function was normal, and that there is no regional wall motion abnormality. So, and looking at the coronary angiogram, and the right coronary looks normal, and the circumflex is big, and the distal stalk is just a small branch. It's just the medication alone is good. So main target region is the bifurcation region over here, and the diagonal branch is very big, and looks like a near total occluded region. Also, and the mid-LAD part is 60-70% narrowed region, and we checked the FFR over here. The FFR value was 0.78, the mid-LAD. So, and we decided to treat the mid-LAD as well as the diagonal branch. So, and initially we concerned about the diagonal branch wire opacity would be difficult, but wire opacity is very easy. Take less than 1 minute, and we use the cyan blue wire LAD and diagonal branch, and this is our routine, and we measure the IVUS, and this is LAD part, this is diagonal part, and one of the interesting part, diagonal ostium, we can see there is some calcium in the ostium of diagonal branch, as well as LAD part. We can see some calcium. There is a circular calcium in the middle LAD and the diagonal ostium. So, and we decided to the two-stand technique for this region. Diagonal branch is big, LAD branch is also big, and we decided to balloon crush technique, and everybody is frequently do DK crush technique in our nation. Is a non-compliant balloon, not fully reimbursed by government. We the routine is the non-compliant balloon crush, and so we do pre-dilation 2.0 NC balloon in diagonal branch. And looking at the diagonal branch is very expanded mid part, and the size is not so small. So we should keep the big diagonal branch as well as big branch. So, and we do diagonal branch stenting. We put the drug-eluting stent design 2.75 and 32, and after diagonal branch, and it looks okay. And the distal part, there is some slope, some narrowing portion, and just after stenting is diagonal flow looks okay. Okay, and then we put the high pressure dilation using LAD part, and we put LAD long stent design 3.5 and 38, and this is NC balloon, and this is NC balloon, and we did high pressure NC balloon dilation. Okay, and then we try to crush and the diagonal ostium part. This is crush part zooming, and the prox LAD. We put the 3.0, the high pressure NC balloon implanted up to 18. So problem over here, after NC balloon dilation in the mid-LAD stenting, patient complained acute chest pain after LAD stenting and high pressure balloon. And as you see, there was a complete obliteration of the diagonal flow. And although patient vital status is okay, but patient complained severe chest pain over here. So, and briefly look back the design stent. This is one of frequently used. There was 81 microgram and Novolymus loading stent. This is just open cell design, and the thickness is just H1 is usually not the thicker stenting. So, and the problem over here, and we try to rewiring at diagonal branch. Patient complained acute chest pain, and the repeated failure of rewiring is there is a very difficult step, and the overall time we spent at least 1 hour. There was a overall process of the diagonal branch, and we initially used cyan blue wire, and the second was a choice PT wire that was failed. Third, and the field XT wire also failed, and the next time we used the Crusade, and that was also failed, and we moved to the CTO wire Gaia 2. It was also failed, and everything is a fail, and there was a take 1 hour already, and that definitely this is not easy situation. So, and desperate rewiring a diagonal branch, and finally we select a very most strong wire in our cataract. This is Concast Pro 12, and this is the usually used for the CTO intervention. Even in CTO intervention, Concast Pro 12 is the final step used wire. So fortunately, diagonal os wiring is passed, and this is the movement of the diagonal wire past that there was Concast Pro 12. So, and the anchoring of the LAD using the NC balloon, we try to put the 1.0 compliant balloon, and successfully passed of the ostium of the diagonal branch. And then because the Concast Pro wire is too much stiff, so we try to exchange it to more soft wire, and put the insert of the carbon microcasting to the diagonal ostium, and then the soft wire change from Concast Pro 12 and the BMW wire. And then we do LED anchoring and put the NC balloon. This is a 2.0 and 2.75 NC balloon. We do very aggressive NC balloon dilation and the diagonal ostium as well as the middle diagonal part. So, and we check the IBUS evaluation in the LAD, and as well as the diagonal middle part, and looking at one of the interesting part, the diagonal branch in the posterior part, we can see there is some thrombus-like region over there. So it looks like layered thrombus. So we do, this is a final step tissue balloon, the sequential in LAD diagonal branch and diagonal os. We do very aggressive NC balloon dilation, LAD very aggressive sequential NC balloon dilation, and finally we do tissue balloon, NC balloon dilation, and we do everything for a final optimization. And then still, and the distal part, there is some very tight region, and do put the additional diagonal stenting, and the distal part is much improved. And after remove and the proximal diagonal still, we can see some irregular narrowing over here, and the flow is good, but still the diagonal ostium, there was some irregular margin. So this is the final IBUS, and the LAD part is okay. Diagonal ostium over here, there is some, the layer, the thrombus-like region over there. Although the stent opening is good, there is some layered part of looks like some thrombus, intra-procedural thrombus, but at this time, patient vital status is okay, and the patient, there is no complaint of the chest pain. So, and this is my slide, and we can discuss a lot of things and the discussion part. And the side branch total gelling. And so first the discussion part, that if you select a different stent like a Resolute or Giants and different story, there was our first guess. And the second story is a side branch total gelling. And if you use the different technique like DK crush or tap rather than balloon crush, and different story, there is my second question. The third is at this wiring chaos situation, how do we do? And there was sometimes happen, and that is a very difficult situation. And even after repeated NC balloon and final tissue balloon dilation and the layered intra-procedural stent thrombosis is remained, how do you do? That was my question to the audience and the panel. Thank you for your attention.
Wow. Difficult case, a jailed, large diagonal with a few hours of wiring, but congratulations in your final success story, and I'm sure this patient will do fine. Let's open this up to all of our distinguished panelists. Let's start with Christoph Jensen. What are some of your tips? He put Dr. Park put up a lot of choices where he would have looked back and maybe done things differently. And that's the best thing about a failure, or if you think it's a failure, this was a success, obviously, but what do you learn and how do you succeed? Dr. Jensen?
Thank you, Roxana, for letting me, for inviting me. So it was an excellent case, Professor Park. Thank you. We all know these frustrating feeling when we try to wire the side branch and it looks easy, and the first wire doesn't work, the second one, the third one, and I'm really amazed that you went up to the Conquest Pro with a very strong tip to get there. So my first thought was, I mean, I don't understand the reason why you shouldn't go in there in the side branch, and at least when I have an IVUS on the table, maybe this would be the point where I try to do imaging and see what is going on. Especially you do an anchoring, and then only then you were able to go to the microcatheter and the balloon in the side branch. So that there must be some really strong mechanical obstacle in the way. So the thrombus doesn't really speaks for 100% of this one near failure. So I would go for the IVUS first. What is your impression there? Did you consider it, or were you just in the rush to get a stronger and stronger wire to get there?
So, and still, I don't fully understand the exact mechanism underlying how this case is difficult. Is my guess, and although we do not exactly the underlying mechanism, I guess, and the proximal tip was too much overlap. That would be some one of the plausible the mechanism of a side branch opening is difficult. Also, after experiencing in this case, I think if I gonna do some DK crush and we do, and the first step of DK crush and the second wiring would be easy than this like some balloon crushes. So the plausible mechanics and mechanism for this case and some diagonal ostium is too much, protruded in the main branch would be one of the mechanism is the guide wire tears.
I'd love to hear from, no, those are great things, because I think the mechanism is not well understood. The angulation of this bifurcation could have played a role, and there could have been some stent deformation as you really pushed up against with a very large balloon in that LAD. And, if you think about it, it was really a very acute angle. And I think that might have played a role, whether this was tissue versus thrombus, et cetera. You could have easily figured that out if you gave like some Cangrelor or something to see if it would go away. But let's hear from Jack Tan. What do you think happened here, and how would you approach something like this?
I think DW presented an excellent case. I'm not too sure of the mechanism, but the fact that he went to a very stiff CTO wire suggests to me that it wasn't just occluded by clots and tissue. More likely it's some form of stent malformation that I don't quite understand. And it could be that the stent crushed back on itself, almost like back telescope when you reverse crush. One observation is that usually when I go for two-stent strategy, I will try to extend the main trunk stent a bit further back so I can be more comfortable with the port. Sometimes when I'm desperate, I will go with an even larger port balloon, smaller, shorter, and do another port to try to reverse the structure in the side branch and port in before I look at it. I was then looking at the side branch access might give me some clues, but I think the patient was having chest pain and struggling, so I think it's a good bailout. At that point, in terms of wiring tricks, Professor Roffi talked about supercross and all this, but twin pass or crusade catheter is something I would try first. I would usually go with hydrophilic wire in this case. And most times, if I'm concerned with angulated two-stent strategy, I leave a wire trapped because that gives me some support as well as a marker to recross. And if I'm desperate, I will slip a small balloon under the trapped wire to try to open up the side strut. So see, these are some of the things I would do in this case, but I'm not too sure of the mechanism. But thanks, DK.
Yeah, no, I think this was really tough. I think there had to be something really stiff there in order to explain this. Professor Chan, any thoughts on this? Andy.
Yes, I think the main issue is we don't quite sure the mechanism, and I think the tissue prolapse is really a possible things that we did consider, and it's difficult, but I appreciate your effort in doing all this, and I think it's a really great case and to learn. Yeah.
Any other thoughts? I'd love to hear from Professor Brian Pying-Yang.
Hi, Roxana. Thank you for that. Again, I agree with Jack. I'm not quite sure about the mechanism, but the fact you need a conquest probably makes thrombus a bit less likely. Because if you think it's thrombus, I would expect you'll be able to wire more quickly. But so whether it's, I think some people mentioned whether it's just purely from a stent crush or from some calcium or some other, maybe a flap or tissue. But I mean, it's a great case. I think you've come up very well. So, but that's
anyone want to? Yeah, I think it was very difficult. Any comments from anyone that we might have missed? Would you know, the one wire you didn't try is the whisper wire, but I don't think whisper would go because there was some crushed something in there. And I'm surprised. But what was interesting is that after you put in the Conquest Pro and crossed, you were able to go in with an IVUS catheter, right? You were able to do that. So you would imagine you didn't have that much of a difficulty. Is that right?
So, and you know, after the wiring, the Conquest Pro, I put the LED anchoring and then the implantation using 1.0 and the smallest smallest balloon, and then 2 and 3 times, and then I put exchange the soft wire and then evaluate the IVUS.
One other point, if I may, is that sometimes I do always go with a non-compliant balloon in the side branch to crank up the ostium before a balloon crush. The other point is that some of those more tighter mini crush, you have to take note of the stent type. I'm not too sure about design, whether there's some closed cell design right at the tip. Sometimes it can also make it more difficult to rewire and recross.
Yeah.
Well, this was a really fantastic case. Maybe you can tell us what you did with the antiplatelet regimens during and after, and whether or not with all of that chest pain in 1 hour, was there a peri-procedural infarction?
So, and this patient, you know, so we keep the CCU and the 2 days, and the patient absolutely stabilized at this time. At the time of discharge, we just prescribed the aspirin and the Plavix. This patient was stable angina. Yeah, I think the aspirin plus ticagrelor would be one of a very nice option, you know, on the basis of trial.
Okay, any other last thoughts? I'm gonna turn this right back to you, Dr. Chan. Thank you so much, Professor D.W. Park.
Okay, thank you.
Thank you, Professor Chan.
Okay.
Back to you.
So and the time is on. I'm gonna introduce then the case 3 and the doctor and I'm gonna introduce the third speaker, Dr. Carl Long Choi, and from Hong Kong. And Dr. Choi is associate consultant and prince of the Wales Hospital, and I hope that he presented well. Is one of the very complex cases. Dr. Choi, please.
Thank you very much for a kind introduction. Good morning, good evening, and good afternoon, depending on where you are. So I'm going to make sure you see my screen and hear my voice.
Okay, good.
Do you
nice.
Good. Okay, that's great. So my patient is a 69 years old gentleman who is a smoker. He got history of hypertension, hyperlipidemia, carotid artery stenosis with history of TIA in 2015, and subsequent left internal carotid artery stenting in 2019. And he got ischemic heart disease with stable effort angina, and the coronary angiogram show a left main of 60% stenosis with pressure damping or using the 5 French diagnostic catheter, and there's proximal to mid LAD 80% stenosis, diagonal diffuse 80 to 90% stenosis, and mid cert focal 90% stenosis, and the mid RCA is minor disease, and distal PLV branch having a small 60-70% stenosis. So we discussed with the patient about the option of CBG versus multi-vessel PCI, and he opted for PCI. So this is the coronary angiogram, the LAO cranial wheel showing the RCA, and there is mid-RCA minor disease and distal PLV branch, some moderate to severe stenosis. This is the RAO wheel showing the RCA, showing only minor disease in the mid portion of the RCA. So because the coronary angiogram was done before, so I got the roadmap in the CAT lab. So I go with the guiding. So I usually don't do senior angiogram with the guiding because sometimes if you got bad left main disease and you inject contrast and do the senior angiogram with the guiding, you may end up dissecting the left main, or dissecting, if you intervene the RCA, may dissect the RCA. So what I did is pull up the angiogram side by side, and then I sit the guiding with the cut wire so that my guide did not engage the left main. And I wire the LAD before I do this senior angiogram. So what you can see is there is moderate severe stenosis in the left main. There's severe disease in the proximal to mid LAD, and there's severe disease in the diagonal branch, which is quite a sizable diagonal. And there is a focal, there's a focal stenosis in the mid circumflex. So this angle, the bifurcation angle, is unfavorable. The disease of the diagonal is long and involving the ostium. So my surgery is to do a two-stent technique for this LAD D1 diagonal branch. So what I did is use a more 2O balloon to predilate the diagonal and also the LAD. I do IFUS to both the LAD and also the diagonal branch. And then I put a 225 long DS just slightly protruding into the LAD. And I park the LAD with a 3O balloon, NC balloon. And then I crush the stent after the stent deployment. So this is the stent deployment. I post-dilate with a 225 and 25 balloon. And then I park a 35 long DS from left main to mid LAD. So this is the result. So I rewire the diagonal and post-dilate the LAD with a 3.5 NC balloon distally, and then I 4O balloon in the left main. And then I do the balloon post-dilatation to the diagonal. So I found difficulty in passing the 2.5 used NC balloon and also the 2O balloon. So I use a new 2.5 NC balloon, but however, it's passed too easily. And actually, without my notice, I keep on pushing the balloon, and finally, I noticed that the guiding actually back off. And I pull back the balloon and then do the balloon post-dilatation to the diagonal, and then final kissing balloon in the LAD D1 diagonal. So this is the kissing balloon inflation at the LAD and D1. And this is the port in the left main using the 4O balloon. So this is the result. So what you notice is there is a LS type 3 perforation in the distal diagonal branch, and it is most likely caused by my balloon. Actually, because the used NC balloon cannot pass the side branch, and I use a new NC balloon, and it actually went too smoothly without my notice, and I got like some poor eyesight, maybe, and the balloon actually passed beyond the wire tip and caused a LS type 3 distal perforation. So what you need to do at first is to put a balloon to occlude the D1. So I put back the 2.5 balloon and inflate at low pressure, and so as to buy it some time. So at the same time, I check an ACT. Of course, I don't want to reverse heparin at this juncture because I still got some gear in the coronary system. So what I did is give the patient fluid and also set up an IV access, the central vein access in the frame wall. And then I do but the patient cannot tolerate the prolonged balloon tamponade. So I have to deflate it on and off to relieve the symptom of ischemia because there's at the same time some ST elevation in the lateral leaks. So because of this bad dissection, I don't think a balloon dilatation, a balloon occlusion is going to stop the bleeding. So what I did is prepare the coiling. So I did it in not a correct way, but I will show you what I did. So this is the microcatheter. I accidentally lost my LAD wire, And the microcatheter is in the diagonal branch, so I deployed 2 coil. So this is the first coil, still ongoing extravasation. For some reason, I cannot detach the coil, so I have to retrieve it back, and I kink the microcatheter at the same time. So I changed to a fine cross into the diagonal branch. So this is the contrast injection through the microcatheters. You see the active extravasation, a very bad distal dissection by the balloon tips. So I prepared the coil again and put 1 coil. It seems still ongoing extravasation. And patient become very unstable with systolic blood pressures only 80. So I try to did an echo, and it's only very tiny amount of pericardial effusion that I cannot, reliably tap it. So I give some intracoronary adrenaline to boost the blood pressure and give some more fluid. And while at the same time, put in 1 more coil and see. So I deploy 1 more coil down, and this is a second coil, a 2 by 10 millimeter coil. I did the coronary injection through the microcatheter, still ongoing extravasation. So it's very, in patient with acute tamponade, it's not uncommon that it's only accumulation of very small amount of pericardial blood can result in profound hemodynamical suppression or even PGA arrest. And pericardiocentesis in this situation is very difficult. And there is a risk of puncturing the RV free wall by your puncture needle. So what I use nowadays for very little, pericardial effusion. So I will use a micropuncture set. Even if you puncture with the RV with this micropuncture set, it's usually seal off not so difficultly, because I've encountered cases that I use a 21 gauge needle that puncture the RV, and then subsequently the bleeding stop, but the RV continue to bleed, and the patient has to have an open heart repair of the RV. So from that time onwards, I changed my practice. Sometimes I use a micropuncture needle if there's not much fluid in the echo. So I punctured a few times and successfully get the access. I use the inner sheath of the microcatheter to drill in, and then use the agitated saline method to confirm my position before I dilate it with the dilator and also insert the pigtail. So after accessing the pericardium, I aspirate the blood pressure immediately improve. And I also, because I got a central vein access, I do the auto transfusion by using a 3-way lunar stop clock with male-to-male connector. You have to stock some male-to-male connector in your cath lab to connect the pigtail to the femoral vein sheath. And this limits the need for blood transfusion and also the potential massive transfusion related complication. But if you do that, you must have a therapeutic ACT, not too high and not too low, because there is chance of getting some thrombus injected back into the circulation. So after the pericardiocentesis and some more time, actually the hemostasis was achieved and no further bleeding. So I actually, the way I did this is not correct. What I think back is I should keep the balloon tamponade in D1, actually use the LED wire or another wire to wire the diagonal branch, and keep the balloon inflated during that time. Only if you wire at D1, you deflate the balloon and wire quickly, and then to inflate the balloon again. And you load the microcatheter over the new D1 wire, and then use the D1 balloon as a trapping balloon that you can push your microcatheter to your target site and quickly deflate, advance, and then inflate the balloon back. It helps to keep the balloon off time minimal, so as to while attempting the coil. So if you need, you can inject contrast via the microcatheter. And coil can be delivered while keeping the balloon inflated, so that you will keep the bleeding minimal. If you have proximal perforation, then you can use ping pong guiding. So if you have distal perforation like this, actually you could keep the balloon, use the second wire. And this helps to keep the balloon off time minimal, and so that the patient won't went into a tamponade situation, very traumatic to me. So if you had distal perforation, if unstable, call for help and inflate the proximal balloon, prepare for pericardiocentesis. And if the patient is stable, we could check if balloon tamponade can work. But if in this kind of big perforation, not wire perforation, most of the time you need to do something. So if it fails to seal, you could consider like microcoil, fat emboli, clotted autologous blood, thrombins, etc. If it's sealed, then you okay. If you're not, then you go through either a other set or even using other things, or if the distal bifurcation is in the side branch, you could cover the main branch with a cover sand, but this would lose the diagonal branch. But consider reversing the heparin only when you remove everything because there's risk of clot in the main branch. So this ends my presentation. Thank you for your kind attention.
Okay, thank you, Dr. Chu. And this is a very wonderful case presentation. I think that this is a very lot of things that we learned from this case. So, and the discussion and panel, and any comment or any question to the presenter?
Maybe a quick comment about the tab. I think in the smallish tab, I try to use a Teguh needle. What the EP does for a dry pericardial tab, that's fairly safe as well. The other thing I want to ask Dr. Chu is that technique you showed gave me a wonderful idea. It was a great sharing. If you have it trapped, would you consider balloon up and then injecting thrombin? Then it seems quite safe. If you have a balloon guarding the LAD and then just using thrombin rather than coils, would that be something you'll consider?
Actually, if you inject thrombin, then it's unpredictable. If you coil, you can be more predictable. I mean, you can see there's a small branch, one in superior one and then inferior one. If you coil both, then the whole diagonal will go from both because of no outflow. So I have to coil as distal as possible. And coil is the advantage is it's controllable and you can seal it. If it doesn't look good, then you can retrieve it. If you do fat emboli, if the fat is big and then it lock up in the bifurcation, then you lost the whole diagonal branch. And if you inject thrombin, there's a chance of spillation. I have no experience with using the thrombin, so probably I would still try to use coil if available in my shell. If it doesn't available, probably I would consider fat or even the Wyco wire. I mean the absorbable coronary. I mean the absorbable stitch that you could just like described by Dr. Lam Ho. And actually, you can use something, I mean, fat would be my choice. And I don't have thrombin in my lab. And probably coil would be my first choice because I'm more familiar with this.
Okay, Dr. Lam, and could you do you comment, Dr. Simon Lam or Dr. Ho Lam, and any comment for this case?
Yes, so maybe Lam Ho first.
I think, Dr. your case is great. You had demonstrated the use of micropuncture set for those precardiocentesis. That is some very important technique because in the early phase of those distal perforation, the pericardial effusion may be just very small, but still can result in tamponade. The use of these micropuncture sets may help a lot. As you mentioned, for this case, in the old day, I will also struggle. But nowadays, next time you try, just use the absorbable wire, Wyco, and then you will left nothing. You just put the microcatheter down and then inject, and then localize the perforation site, and then push 3 mm or 4 mm absorbable VO Wyco down, and maybe. In your case, because it's not perforated by wire but by balloon, so probably you may need 6 times or 8 times just push the Wyco in. We had tried a few cases recently, all okay. And in your case, there one tips and tricks I want to share. I see you push the microcatheter down to the point of perforation and then inject the contrast. Sometimes that can aggravate the perforation. So usually I will take the microcatheter maybe 3 to 5 centimeter, take it a bit away from the perforation site and then inject the contrast so that you won't aggravate the perforation. That is my sharing. Okay.
And for me,
yes, I agree.
Yeah. So learn from this case, and I think for these scenarios is just to use something that you're really familiar with. I think learning to use the coils and also the absorbable sutures. But for me, the fastest thing to use is the fat embolization and control the size. So it really depends on what you're really familiar with and to help the patient as soon as possible. And for the puncture site, I think with the X-ray, it's very easy to do. Even there's a very minimal effusion, you can use the wire to confirm. You can do a little bit injections, even for we're trained for dry tap for structural intervention. So I think with X-ray, you can really confirm even there is any very small effusion. And last word is for the auto transfusion. I have some hesitation because sometimes for some patients, I have experienced that it triggers some immune phenomenon that really the patient goes into DIC or anything. If it's really a lingering process, I would still prefer fluid resuscitation, timely tapping, and call for blood packed cell transfusion. So for me, if there's any anticipating complication, I would do the tapping really early on. For structural heart intervention and for PCIs.
Yeah, definitely. There is the question is same. Some we do during the very urgent PCI or urgent top-up procedure. We sometimes do the auto transfusion, but anesthesiology doctor is very concerned about the safety of auto transfusion. Is any sort of the panel or discussion about the auto transfusion?
Yeah, I fully agree that actually it may seem that at the very first sight it may seem a very elegant option, but indeed I have also great concern about this DIC-like process. So actually I do not perform auto transfusion anymore.
Okay, and Dr. Lo, Sidney Lo, any comment for this case?
I was just going to comment that most of the cases just means the operator has to be very comfortable with doing these procedures. Pericardiocentesis is a must. So, and also ability to stop the bleeding, particularly perforation in terms of coiling or fat embolization. I think one of my friends told me, most patients have some fat in the groin, and so it's hypoallergenic, and you don't leave anything behind. And so essentially it looks pretty good if it works. And so I think that if we, as operators, particularly junior doctors, learn how to do this so they're not freaked out when they're doing this in an emergency situation. I know the EP doctors do the pericardiocentesis in a different way. They're doing a lateral view. And I think that we just need to know how we're going to do it with a micropuncture kit, and that everything's available. So we, in my lab, we now have a pericardiocentesis trolley. So it just gets wheeled. Everything is there. And we don't have to run away. The nurse is not running away. It's all there and it's all available so that you don't freak out. It's all confident. And of course, a hemostatic trolley as well, with all the coils, microcatheters, everything is in one place and it's always available.
One final point I want to make for the micropuncture site is usually the needle is shorter. I mean, you may, for obese patient, you may not be long enough. The other thing is the wire is short. And if you want to confirm with X-ray, it's not easy with the micropuncture wire because you can't insert the wire all the way to see the wire go through the anteroposterior and left and right a different chamber. So what you need to do is do agitated saline to confirm before you actually dilating the tract. I mean, this is a must. I mean, the wire is not long enough, and also the needle sometimes is short. It's only for thin patient.
Yeah, I think the micropuncture kit technique was pioneered by the Mayo Clinic. So in their paper, that 1,500 cases, they were basically apical tap. So that was their preferred approach. So it's not so long. So you're right. If you're doing subxiphoid, it's not a subcostal approach. It may be too short in a large patient.
And something I learned from Eric and my colleague and a good friend, and is that you can use a 0.018 wire and to do the process. I mean, a longer wire, because the wire that goes with the pack is very bad. I mean, the transition, the soft part and the hard part is very bad. It's kinked easily, and so I would use another better 0.018 wire.
That's just like steel core, right?
So I think one of the important educational point of this case, and any PCI procedure is I recommend for our juniors to keep the all wire to end of the branch, LAD end of a branch and diagonal end of a branch, and keep the stabilize the wire and the end of the branch, and we avoid such like a complication, the procedure.
Okay. Can I make one comment?
Okay, great.
Yes. So I have one comment about the hemostasis. Maybe can I share one picture?
Okay. You can share one picture.
Yes. Can you see this paper? So this is my published paper. So maybe for putting the call, he concerned about the bleeding or stop bleeding. So with prolonged barrel inflation like this. So if we put the microcatheter to put the call like this, so deflate immediately and put microcatheter and wire here. And in this paper, I talked about severe at the severe population, we can inject the patient arterial blood for distal part, so we can perfuse arterial flow. So we can perform very long barrel inflation, more than 20 minutes. So I performed this procedure a few cases. So it was very effective. So not only injecting arterial blood, but putting thrombus or putting cords, it is very effective. So that I mentioned.
Great.
Thank you.
Okay, so and the time is on, and we're gonna move to the case number 4, and I'm gonna introduce Dr. Rahul Sharma, and from United States, and he is the director of the structural intervention and Stanford Healthcare, and the clinical assistant of a professor of medicine at Stanford University. And Dr. Sharma is interventional cardiologist with a specialized clinical and research interest in the structural heart disease. Dr. Sharma.
Thank you, Professor Park and colleagues. Thank you for the kind invitation. I hope you can see my screen and hear me okay.
Okay, great.
Terrific. So I'm going to change the cadence and the flavor a little bit from complex coronary intervention to complex structural intervention. This is my most thrilling case, at least recently. We have plenty of thrilling cases, but hopefully this one is somewhat entertaining and instructive. So this is a patient a little younger than we're used to seeing in structural heart. This was a 30-year-old, very unfortunate female. You can see here a very complex, extensive list of comorbidities. She had AML at age 7, had chemotherapy, whole body radiation, had multiple complications as a result of both her primary disease as well as her treatment. She had lung disease, significant graft versus host disease. She had hepatocellular carcinoma, ended up on end-stage dialysis. In secondary to end-stage dialysis, had systemic calciphylaxis, and you'll see why that is important shortly. Bilateral lower limb osteomyelitis with digital amputation. She had a papillary thyroid carcinoma and multiple thromboembolic complications with visual loss and digital infarcts, as well as DVTs and PEs. And she had an issue of chronic hypotension, which was particularly worse on hemodialysis, and was on medications to try and control that. Complicating all of her treatment, she ended up having a chemotherapy-induced cardiomyopathy with significant symptoms and orthopnea. She had an initial improvement in her ejection fraction once her regimen was altered, but eventually had worsening of her ejection fraction and hypotension on those dialysis days. She had repeated echoes done throughout her treatment, and these show these fluctuating echogenic masses of calcification seen in the left side of the heart, on the right atrium and the septum, and involving the mitral leaflet with moderate to severe mitral regurgitation. So she was admitted to hospital with a worsening of her ejection fraction, worsening of her symptoms and degree of MR, and after consultation with the multidisciplinary team, a thought was given to pursue intervention in the mitral valve as a last-ditch effort to improve her quality of life. She was seen by the surgeons, of course, and they thought, given her high surgical mortality, a percutaneous approach would be better tolerated than surgery. And so this is her baseline echocardiogram. You can see here significant calcification, the caudal structures, the wall of the ventricle here. You can see echogenic masses flicking around on the mitral leaflet and thickened mitral leaflets as well. And you can see here she has mitral annular calcification and significant mitral regurgitation extending all the way back to the left atrium. So we elected to perform a mitral clip procedure with a degree of trepidation. Given all of that calcium there, I used a cerebral protection device with the Sentinel cerebral protection, and in the usual way from the right radial approach through a 6 French sheath and articulating the 2 baskets to sit in the right innominate, and then the second basket you can see here in the left common carotid artery. Given the fact that we were going to be instrumenting the left side and we didn't know what would happen to those echogenic masses, we thought it most prudent to protect her brain. So she also had a tunnel dialysis catheter, which I'd never encountered to be a problem before, but in this case made it extremely difficult to try and perform the transeptal puncture. The tunnel dialysis catheter was actually sitting right in front of the septum. So despite the use of multiple modalities to perform the transeptal, you see here I'm using the SL1 catheter, which is my first go-to. But despite the use of an SL1 and an Agilis and multiple other catheters, the actual tunnel dialysis catheter was sitting right in front of the septum. You can see here in the panel on the right, so I could never get onto the septum. And so what we did is we asked the interventional radiologist to come and pull out the tunnel dialysis catheter. And we all learned something that day, and that is that even though you pull out the catheter, after a catheter has been in for some time, there is a residual fibrin encasing around the catheter, which actually can be quite firm. And so what you see here on the 3D image, as well as on the 2D image, is actually the tunnel catheter is out, but this is the residual fibrin casing around that catheter. And so still there was a mechanical obstruction to performing the transeptal puncture. And so you see here, I now have an Agilis catheter, thinking if I have more support, I'll be able to get around it. But in fact, there's still a mechanical obstruction between the Agilis catheter and the septum. And so thinking sort of on the spot, what I decided to do in consultation with my IR colleagues is actually to balloon fragment the fibrin sheath. And so I wired the balloon sheath and actually ballooned it and broke up the fibrin casing that was obstructing the passage to the septum. And now you see here, there's some residual fibrin material flicking around, but now we have a very clear run to the septum with no mechanical obstruction to the septum. And so this time with the Agilis catheter against the septum, you can appreciate that the septum is quite bright as a result of the calcification. It was very rigid and very thick. For those of you who do a lot of transeptal procedures, you'll appreciate that a lot of time we get mechanical tactile feedback from the septum, and you can actually feel the pulsation while you're on the septum. There was no such tactile feedback here due to the calcification. You can also appreciate that the degree of tenting is very subtle, again, because it's a very rigid septum. And so again, I'm using the Agilis catheter here for additional support, and the BRK needle would not puncture. So I did something a little bit unorthodox. I took a stiff end of an 035 wire, the back end of an 035 wire, and passed it through the Agilis catheter and actually electrified the back end of the 035 wire. And so you can see here that was successful in puncturing through this rigid septum. What I then did is very carefully exchange that rigid wire using a full French micro catheter. And you can see here just very carefully advancing it and twisting it, just sort of spinning it through that septum so that that stiff wire didn't jump through and perforate the posterior wall. And then you can see here the soft full French catheter into the pulmonary vein, and then we exchanged over that. Did a balloon septostomy. Again, this is not routine in my practice for a mitral clip. More often than not, you have a supple, soft septum, and so passage of even a 24 French mitral clip system through that is not a problem. But again, given the difficulties we faced with traversing the septum in this case, elected to perform a balloon septostomy here with a 12 millimeter balloon, just very slow inflation to ensure that we wouldn't get hung up with the mitral clip delivery system across that septum after all of this hard work. Now, I will tell you, getting to this point had taken about 2.5 hours, which again is not routine for a transeptal puncture. So thereafter, we advanced the mitral clip in the routine fashion, and not really knowing what to expect with grasping these leaflets, given the degree of calcification and given the degree of those echogenic masses. And so that was fairly routine in terms of traversing the mitral clip under careful TEE guidance to ensure we did not get caught up in those calcified cords or knock off any of that calcium. And you can see here, this is us trying to grasp the leaflets, being very careful to try and avoid a lot of this calcium. But you can see there the anterior and the post-anterior leaflet on the right, posterior leaflet on the left, ensuring that we have adequate leaflet all the way into the V before gently closing this under guidance. And so you can see here, we've closed the clip and there's a significant reduction in the mitral regurgitation, very little residual mitral regurgitation there. But of course, we want to be very careful because sometimes we can mitigate all of the mitral regurgitation and then end up with significant mitral stenosis. And given the calcification here, that was certainly a concern. We're very pleased to see that her residual gradient was only 4 millimeters of mercury. And so we elected to deploy the clip. And you can see here the on fast view, we have the still that chunk of likely thrombogenic or calcified material here on the posterior aspect is still there. It hasn't gone anywhere. We've created this kind of Alfieri approach with a double orifice mitral valve with very little mitral regurgitation left through there. And again, we weren't sure how this clip would behave post-deployment with the tension on this leaflet and the nature of the tissue, leaflet tissue. And so we were very pleased to see that after deployment, we still had very little residual mitral regurgitation. We were left with this iatrogenic ASD, which is not infrequent when we do these transeptal procedures. I would say the majority of the time when we have a left to right shunt, in the absence of any bidirectional or right to left shunting, in the absence of desaturation, we tend to leave these alone. However, given the patient's prior history of multiple thromboembolic events and her tenuous state, we actually elected to close this iatrogenic ASD, not because of any hemodynamic issues, but rather to protect from any potential thrombogenic issues going forward. My preference for device use is the Gore device. It's a very simple device. It comes in two sizes, a 25 and a 30 millimeter device, very simple to deploy. It's effectively one large coil, which creates two discs with a PET material fabric throughout. And you can see there, we've successfully closed that ASD and there's no flow through the device or around the device. We used a 25 millimeter device here. And so we retrieved the sentinel, and you can see here, there is quite a lot of foreign material. I think, there's a lot of controversy about the use of cerebral protection, certainly in TAVR, but in this case, I think it was the right thing to do. And you can see there's quite a lot of dense material there. I'm sure if we sent that off for analysis, we would found that it was probably a mix of immune complex, tissue material, and calcium. And so the patient did quite well, was discharged 2 days after the procedure. Her main complaint was back pain from lying in bed for too long, but continues to do well now. This is 3 months after the procedure with no rehospitalizations for heart failure. And so this is just to show you the side-by-side comparison of what we started with and what we ended up with after one clip in the mitral position. So I'll stop there and take any questions or comments.
Okay, great. Thank you, Dr. Salman. This is a very complex and this is very wonderful case. Any comment from the panel or discussion for this nice case?
So thank you very much, Professor Sharma. So may I ask, how often do you use sentinel protection in non-TAVI cases? So for example, we may do sometimes do mitral procedures, for example, PBMV. We found there may be a lot of clots or degeneration, or sometimes we do valve-in-valve mitral prosthesis, in which there may be a lot of calcium debris. So we may do it, but sometimes we really can catch something. So what is the threshold of using the protection device in non-TAVI cases?
Yes, that's a great question. My personal preference is I'm a strong believer in cerebral protection, both in the TAVR and non-TAVR space. However, I need to balance my own preferences and desires with health economics, and it is an off-label use, of course. And in the United States, while we have a new technology add-on payment for it, there is still an out-of-pocket expense. So I'm unable to use it in all cases, but similar to what you just described, very calcified, any sort of material we see on the left side that could be thrombogenic. So those complicated valve-in-valves. I don't use it so much for valve-in-ring. I certainly use it when I'm doing any valve-in-MAC procedure, whether that's a TMVR or a SAPIEN valve in the mitral position. And I think, as we have better devices and more evidence, we might see it being used more often in non-TAVI left-sided procedures as well.
Thank you.
Great.
Maybe I have a comment. Go ahead, Roxana.
That's okay.
Roxana.
An amazing case and a difficult one. I'm still struggling with whether or not, with all of the things that's going on in this patient, whether or not you needed to close that ASD to give her yet another device inside of her body. And I wondered, access to this mitral valve the next time, if let's just say she another reason to go across that septum, etc., might be really, really difficult, almost impossible. She's only 30 years old. So I'd like to hear your rationale for closing that ASD.
Yeah, great question, Roxana. While I presented it very quickly from slide to slide, that decision took a lot of deliberation in the lab. And we went back and forth for quite some time. All those points you raised were discussed and thought about, the need for re-intervention, the need to re-access the septum. As I said, it's not our routine to close these, particularly looking at those echo images. In any other case, we would have left this alone. I think there was a great pressure both from her referring and some of the others in the room, in that she'd had so many thromboembolic complications that, if there was any hemodynamic situation under which that shunt reversed, a stroke would be catastrophic in this young lady. So I think, I agree. It's certainly not the right decision one way or another. And I think on balance, at the end of it, I decided that the chances of us going back in for another left-sided procedure were fairly low. This was kind of her last-ditch attempt. No one really wanted to instrument her again. The surgeons certainly weren't going to touch her. She's not a transplant candidate at this stage. Mm-hmm. And so this was really more for a symptomatic benefit to keep her out of hospital, and therefore the chances of a repeat intervention are low. And I thought the chances of a stroke, albeit small, were probably kind of larger than that. And so in the end, we decided to close it. But you're absolutely right. Whether it's the right decision or not, I'm not sure. But on balance, that we felt it was the right thing at the time.
Yeah, maybe in this respect, I assume that the patient, based on the heavy background of multiple DVTs and PE, was the patient anticoagulated? This is my first question. And the second is just a comment. We do not have restriction in Switzerland currently for EPD in TAVR, so we use it in our center routinely for TAVR and for selected mitral procedures such as a valve in bioprosthesis.
Fantastic. So to answer your question, yes, she was on anticoagulation. In fact, some of her thromboembolic events had occurred while on anticoagulation. So she was quite a high-risk patient in terms of thromboembolic events.
So do you have any comment, Gary?
Okay, go ahead. Okay, Dr. Chair.
Oh, I'm asking Dr. Gary Cheung, do you have any comment? Dr. Cheung is our structural heart disease expert. You have to unmute the microphone.
Yes, hi, thank you, Dr. Chen. Yeah, it's a good case. Thank you very much. I think it's a good case. I noticed that this is not a routine to use a protection device in this mitral clip case, because usually there's not much clot that we can retrieve from this mitral clip case. On the other hand, we noticed that Otavio, of course, will use CAFID for every TAVI case. In this situation, it is so rare that we will retrieve a lot of clot. So where do you think the location or the source of the clot from the carriers?
So I think, correct me if I'm wrong, sorry, there's background noise. The question was, where do you think the source of the material was from this sentinel? Was that the question?
Yeah.
Okay, so our thought, and we sent this off for histopathology. Our thought, and we sent this off for confirmatory histopathology, was that it was likely material from the valve itself, and there was actually a mix of thrombus, some calcified material, and some leaflet tissue as well. So it was basically from the valve itself. There might have been something from the transeptal puncture to account for the calcified fragments, but I think most of it was from the valve itself.
Yeah, I think so, because when you pass the system through the septum and also do cracking, then you may stretch a lot of things go into the LA. Another thing that for the valve itself, because you only touch the valve when you clip. So I think the contact of the system to the valve is less compared with what you manipulate around along the septum. So I think, why not put in an embolic protection device? And this certainly helps the patient in this sense. Mm-hmm. But don't forget, we are talking about the ASD and the coagulation and anything. But I think most importantly, this is a difficult case for the mitral clip because you only have very small margin. You have a calcium there. You want to avoid that. You want to balance between residual stenosis and the elimination of mitral regurgitation. So overall, it's a tragic case for the mitral clip.
Thank you.
Thank you.
Dr. Sharma, NY Chen. It's a nice case, great. We have about your transeptal puncture. It's a very difficult transeptal puncture. I presume that you have tried the extra sharp needle, Another option would be the radio frequency transeptal needle. That may help if your lab have stocked that.
Yes. So we actually tried the Baylis radiofrequency needle, but the needle itself didn't quite have the strength to get across. The radiofrequency part wasn't a problem, it was just pushing through that septum. And so that's why I ended up using the back end of the stiff wire just to have that mechanical force in addition to the RF ablation applied to it with a Bovie on the back end. But absolutely, we have access. Our EP colleagues use that routinely. I don't use it routinely. I use it in difficult cases. But generally my go-to is the SL1 and BRK1, but absolutely.
Thank you.
Dr. Jensen, you have some comment?
Okay, go ahead.
Yes, yeah, I have some comment. If I do the case, I think I will chose ASD because can you hear me? Can you hear me?
I'm sorry, it's very distorted.
Because it seems that the shunt is left to right, and there's low significant right to left side. In this situation, sorry.
Sorry.
I'm sorry. Can you hear me now?
Yes, better.
Can you hear me now? Sorry. Can you hear me now? Sorry.
Yes, speed. Yes.
Yeah, can you hear me now?
Okay, Dr. Cheung, and your internet connection is very unstable.
For me, I won't close. Yeah, sorry. Usually, I will observe this before close the ASD closure. Usually, I will close the ASD after retro clip if there's a right to left shunt, and also if there's any desaturation after the mitral clip. So if I prefer, I think I will observe whether to close the ASD directly. So this is my opinion for your case. And also, of course, to see the any desaturation if I remove the cap. Yeah. Sorry, can you hear me?
Yeah.
Maybe Dr. Jensen, you have some comment?
Yes, thank you. It was a great case, Dr. Sharma. I really enjoyed it. I do a lot of mitral clips myself, but experienced a couple of problems and doing transeptal, but never had a fibrous channel in front of the septum. So as I understand correctly, you fragmented it, you shattered it with a balloon, and out of curiosity, what did you do with the fragments? Did you snare them? Did you get a forceps and took them out, or?
No, so the IRF team felt that they do this apparently a lot when they're replacing these tunnel catheters, and they were saying that they just fragment away. They don't usually do anything for them. You could see on that echo there was a few adherent strands still there. We elected to leave them alone. We were very careful as we were crossing and doing our transeptal not to take any of those strands across. We were being very careful under TE, but we left it alone. We did nothing for that right side.
Okay, great. So next time when I experience a tunnel, then I know what to do.
Right. That was my first time too.
Sorry, but in this respect, what balloon size did you use? Because I mean, the superior vena cava is a quite large vessel.
Yes, no, so we just chose the balloon size based on the fibrin sheath size of the around the tunnel dialysis catheter. And so I think we used a 12 or a 14 balloon.
Okay, great. So any comment from Ketchum? Okay, I think time is up. I'm gonna move the discussion role in my button to Marco Roffi. Could you please introduce the fifth speaker?
Yes, first of all, let me thank the Hong Kong College of Cardiology and his president, Dr. Chan, for this kind invitation, as well as the course director, Dr. Chan, Dr. Simon Lan, and Dr. Holam. It's really a pleasure and honor for me here today. And it is also my privilege to introduce Professor Teguh Santoso. He's from Jakarta, Indonesia, Medistra Hospital. And he was trained in Indonesia and then at the Thorax Center. He's professor of internal medicine, and he has a wide variety of interest in the field of interventional cardiology, going from coronary to peripheral to structural heart disease and even stem cell. So really a very broad skill panorama. He got multiple awards, and it is my pleasure to invite him to present this case.
Thank you so much, Professor Roffi. And first of all, I would like also thanks the organizing committee for having me joining this very prestigious webinar, in particular also Dr. Simon Lam. This is a case of catheter-induced aortic dissection, Stanford type A, Dunning class 3, with occlusive spiral dissection of the right coronary artery and perforation. Allow me first to review risk conditions for these situations. Of course, one of the predisposing factor for this is long-standing hypertension, which may be associated with smoking, dyslipidemia, cocaine usage, and crack, and also connective tissue disorders. Nowadays, we are dealing with a lot of patients with bicuspid aortic valve, which has often has the aortopathy also as well. And another situation related to connective tissue disorders are, among others, Marfan syndrome, Ehlers-Danlos syndrome, vascular inflammatory disease, and so on. Deceleration trauma. But in this particular occasion, I would like to present a case which presented with a catheter and instrument-induced dissection. According to the literature, acute proximal aortic dissection is highly lethal with a high mortality rate, and the most common causes of death are aortic rupture, stroke, myocardial infarction, circulatory failure, cardiac tamponade, and visceral ischemia. It carries a high mortality, and it is usually considered a surgical emergency, and the mortality is very high despite medical or surgical intervention. And now, this is the classifications of iatrogenic aortic dissection. This classification is proposed by Dunning, but still adopted until now. He classified the iatrogenic aortic dissection into 3 types. Grade 1, if the dissection involves only ipsilateral cusps. Class 2, ipsilateral cups extending to the aorta but less than 40 mm from the dissected spot. And class 3, if it extends up to more than 40 mm from the dissection. And iatrogenic aortic dissection is more common in cases undergoing PCI, slightly more common as compared to those undergoing diagnostic cath. Slightly more common in patients with presented with AMI, and right coronary artery also more common than left because of the a smaller size of the right coronary artery and less left main intervention. And the risk factors are as follows: heavy vessel calcifications, vigorous contrast injection, stiff aggressive guiding catheter manipulation, the use of stiff or penetrating wires, non-coaxial guide position relative to the vessel wall. And the treatment include conservative management, the use of stent or covered stent to seal the dissection entry, and surgical repair, especially if we are dealing with a Dunning class 3. The mechanism of hemodynamic decompensations are as follows: aortic ruptures, perforations into the pericardium and tamponade, coronary occlusion of the ostium and contralateral ostium with hematoma, propagation of dissection into aortic arch, which may induce stroke, and dissecting aorta, which may induce visceral ischemia, acute aortic regurg, and acute aortic occlusion because of false lumen. Treatment, of course, we don't have clear management guidelines. guidelines are lacking. Dunning class 3 are more likely to need surgical intervention, and this condition is increasingly being managed conservatively. And this is the surgical indications. Usually, surgery is indicated in the presence if we have intimal flap, hemopericardium, hemodynamic instability, coronary ostium occlusion, and arch occlusion. And this is the case. 47 young female. The history is stable angina since 1 year. Risk factors: hypertension, dyslipidemia, and history of hysterectomy. Patient is hypertensive, but this can be brought under control with medications. Cholesterol level is 238, a bit high, and LDL is also a bit high. Otherwise, lab findings are all normal. ECG, chest film, and echo were all normal. Treadmill was positive for ischemia. And multi-slice CT scan and also confirmed by angio showed double vessel disease involving the LAD, tandem stenosis in the proximal and mid segment, and the right coronary artery diffuse narrowing in the mid segment with one focal stenosis also in the same segment. And these are the medications. Patients were put on ramipril, aspirin, clopidogrel, and diltiazem. And in the cath lab table, patient became apprehensive. The blood pressure increased all of a sudden to more than 200. So we had to give dormicum to calm the patient down. And we didn't give additional antihypertensive medication at that time. And this is the angio of the right coronary artery. So after fixing the lesions in the left system, the right was attended. You will appreciate here that the patient is a bit tachycardia, has a bit tachycardia, and there is a diffuse narrowing here in the mid segment with focal 90% stenosis here. We use a 6 French guider. And we tried to use a cutting balloon here, but the cutting balloon could not be advanced across the focal stenosis. And then the patient developed, sorry. So this is just to show diffuse narrowing in the mid segment and focal stenosis here in between mid and distal segment. And this is the cutting balloon, which could not be advanced across the focal stenosis. And then out of the blue, the patient developed sudden severe chest pain, blood pressure declined to 96 systolic, and patient had rapidly progressive Stanford type A Dunning class 3 aortic dissection, extending to the cusp and aortic arc. So we tried to fix the entry point. We thought that the entry point is here. So we put 2 drug-eluting stents. Intentionally at that time, we didn't use a covered stent as the initial attempt because the vessel is rather smallest, and we think that the restenosis rate with the covered stent would be very high. And also there is also, we only have graft master at that time. We also know that with graft master, sometimes we have a foreshortening during the stent implantation. So we have to be very careful with this. So we use a drug-eluting stent, but at that time we noticed also that the right coronary artery has occlusive spiral dissection here. Note that there is no flow here from this point downstream, and there is also extravasations of the contrast agents. But fortunately, contrast injection did not disclose any aortic regurg. So if I may ask your opinion, what is the cause of the perforation and where is the site? I have just 1 or 2 answer here.
So anybody can give his answer about the panelists, the moderators, what? So first of all, the extension, you didn't show the aorta, but we have the feeling that based on the contrast, that we see, we have the feeling that this takes the entire ascending aorta portion, so circular contrast in the aortic. Can you tell us how far did, at least based on contrast, the dissection go more towards the aortic arch?
I will show you the film later on after this. If I may get the short answer about this, what is the cause of perforation, where is the site? You know that whether this is the question is whether this is in the aorta, or proximal, mid-right, or guide wire-induced perforation. Okay, let me proceed. I cannot demonstrate where on angio is the site of perforation, but my postulation.
Sorry. The concept of perforation comes from where?
Yes.
Because why are you telling us? I'm not sure I saw it on angiogram. So why?
You see here there is a contrast extravasation.
Okay. So, but we are not seeing anything coming from the coronary so far, and the distal, the right coronary artery is now occluded. I don't see it coming from the proximal mid portion. So, until least proven otherwise, this could be a pericardial effusion associated to the dissection of the ascending aorta.
Okay, let me proceed. Of course, we need to have a very good blood pressure and heart rate control at the time. And the next question is, I want to fix the coronary ostium at the time. Of course, it would be ideal if I use IFUS, but in this particular case, unfortunately, I didn't use IFUS. But
so maybe a provocative question: why do we want to fix the ostium if there is no flow in the right coronary artery, and you may have the feeling the patient needs surgery, emergent surgery anyway, or you are not thinking this patient needs emergent surgery?
I have to act fast, and I thought that the cause of perforation is in the coronary ostium because of the section perforating the aorta. Even though this is a small but I think this is the origin of the perforation, and then I think that I need to fix that as soon as possible with stent. As I mentioned before, I tried to use a stent and not covered stent for some reasons that I've explained before. So of course, after this, I did the aggressive post-deal. I didn't have an osteal flash balloon like that. So I just use aggressive post-deal. But then the next question is, should I neutralize the anticoagulation effect with protamine? May I have expert panelist opinion? Is it wise or unwise to use protamine?
Avoid it if I can. Coughing can be harder to manage.
Okay, I completely agree with you, Sidney. So I decided not to use, not to utilize the anticoagulation effect because I think that I still need to fix the right coronary artery occlusion. So I probably would think about this after my gear is out. My gear is out of the coronaries. Of course, I need to stop injecting. Otherwise, I may just more dissection. But I still have to do injection because I still need to fix the right coronary artery occlusive dissection. And the next question is, I have to use to do a pericardiocentesis, echo or fluoro guided.
Please go ahead, or you're asking questions.
Yeah, I'm asking questions.
Yeah. For pericardiocentesis, I think like both, but fluoro guided would be good
so
if there's a fluoroscopy.
I don't want to have a second experience, so I want to have your expert opinion. What to do next time in case we have this kind of problem.
So my comment is just again, is a basic strategy. If you plan to go for emergent surgery, then you don't need to fix this right coronary artery.
And I see the distal fold of the RCA was impaired. In this case, usually I will use IFAS to localize the distal landing site for the stent, and then just stent with a long stent from the distal RCA to the ostial RCA, see if I can stop the progression of the dissection or resume the fold in the RCA first. Because this RCA could be very big, and then the patient may result in short if it close.
Okay, let me proceed. So the next question is, do I have to call my surgical colleague?
I thought you already called it.
Yes.
Called him.
That's good. This patient is classified as dining class 3, and also on top of that with complications. So actually this is a surgical candidate. I have to do CT scan.
CT scan is just again a matter of also your surgeon's preference. I mean, if you see clearly that you have contrast going up to the aortic arch, and you are committed to go for surgery, and your surgeons agrees, then one option would go to the OR and having TOE in the OR. But sometimes I know, at least in our institution, surgeons are eager to have a CT scan before going for it. But it depends also on the hemodynamic status of the patient.
Thank you. So, so at that time, I follow Sidney's advice. I didn't do any attempt to reverse the anticoagulation effect on heparin. So I was a bit lucky. I was able to cross to fix the section here. And after pre-DEL, I implanted one DES here, and then subsequently another DES here, 2 overlapping DES to allow full lesion coverage here, because as you may remember, this is a very long segmental narrowing with focal stenosis here. And so we have now we have 4 stents, 2 overlapping stents here, and 2 overlapping stents in the ostium. And this is what we see minutes later. You see more perforation, more pericardial effusion, extensive dissection. This is definitely a Dunning class 3. Non-flow limiting dissection, the proximal right coronary artery. There is still a remaining dissection here, but this is non-flow limiting. But the section extends upward, upstream to the ascending aorta and arch. You see the amount of pericardial effusion. So what to do?
I don't know what can I do. Usually this surgeon's duty, but what I can't do is don't do the pericardiocentesis in this sort of situation, because maybe there's communication between aorta and the pericardial space. The blood will come out if you do pericardiocentesis. Unless in the last drop effect, if you don't do the patient's BP drop and with severe tamponade, you want to release something.
Okay. Any other comment? One more comment.
So the question is also: are you also concerned of the left coronary systems, or just an impression that it may be also compromised?
Okay, that's a very good question. So I tried to look for other potential complications, as I mentioned, involvement of one or both coronary arteries. Of course, in this particular situation, the left coronary system, which may induce acute myocardial ischemia and or infarction, contained rupture into the mediastinum or pericardium, which may induce pericardial tamponade. Patient is not yet in tamponade. Extension of dissection, which may compromise brain perfusion. Aortic valve disruption, which may induce acute AR and induce acute left heart failure, or aortic rupture, which may exsanguinate the patients and leads to death. So regarding all these questions, of course, for the first question, we need to do contralateral angio. Sorry, contralateral angio, but I don't want to lose access to of the right coronary artery. So I maintain the GR catheter in the right coronary artery. Regarding the second question, we know that the patient already have a hemopericardium, but not yet tamponade. But there is so far no neurological deficits, and so far no acute AR or aortic rupture. Very lucky. So using transradial approach, I annulate the right coronary artery, but unfortunately the right coronary artery was still intact. The left coronary artery was still intact, not involved in the dissection process. So this is the right again, still okay. The section here in between the two stents, proximal and mid segment. And at this point of time, what should I do?
I think you should first localize where is the bleeding site. Is it bleeding direct communicate from the aorta to the mediastinum, or is it because the guiding catheter sometimes may damage the cuffs? I had one case similar to this with guiding catheter damage to the non-cuffs, and then continuously, persistently with some blood go to the pericardial space. So first, I think I will localize where is the bleeding.
Okay,
is it from outside?
Hemodynamically stable. Pericardial synthesis, we thought that pericardial synthesis is difficult to perform because still non-significant amount of fluid, even if guided by fluoro or echo. And there is still, fortunately, no neurological deficit and no AR. So this is the situation.
Yeah.
Is now the best timing to refer the case for surgery?
Personally, I would have seen a little bit more of this aorta, but it seems quite large to me, based on the contrast. So I fear that there is maybe really a dissection with a large lumen involving the ascending aorta.
And if
would you do CT?
Yeah, CT can help to localize the bleeding.
Yeah, because he's stable enough at the moment. I don't know there's an indication. So maybe CT may help.
The question is, if you see that the with contrast, maybe you don't see, but if you see with contrast that the entire aortic arch is taken, then at this point in time, the patient qualifies for surgery. And again, you have two options: if adequately stable, CT and then OR, or OR and then TOE.
So surgery is generally advised without delay, of course. I completely agree with you. And the aim of surgery is to prevent or treat complications like rupture, pericardial effusion, coronary cerebral flow obstruction, and so on. And usually the surgeon would implant a composite graft in the ascending aorta with or without implantation of the coronary arteries. But the mortality rate is high, even in centers of excellence. And mortality would be much higher in this case because the patient is heavily anticoagulated. So we discussed this with our house cardiac surgeon, and I don't know whether fortunately or unfortunately, he declined. He declined to operate this patient. So this is after an observation period of 30 minutes. There is no increase in the amount of fusions, and there is after 60 minutes no increase in the amount of fusions, no hemodynamic compromise. Patient was stable. Chest pain subsided. So we have a consensus with the cardiac surgeon. If situation worsens, then he would act. Of course, we thought that if he act, it would be too late. But anyway, that's his advice. So this is sorry. This is the flow chart. Usually, if
sorry, just we have
calm,
1 minute.
we need to think.
Sorry,
we need to
1 minute to finish the discussion.
And
so please tell us in 1 minute how you handle this fantastic case.
And then this is the CT scan at day 3. Unfortunately, it doesn't work. Okay. There is a little bit of irregularities here, which may represent post-dissecting thrombus, but there is no more dissection here, and also shown here. No,
so you did the first CT scan at day 3, or you did it acutely?
Diameter. So even the aorta diameter is not enlarged. And there is also only minimal fluid collection in the mediastinum and the pericardial space. You see here.
So is this your first CT scan at 3 days?
This is at 3 days.
Is the first you did?
And then, of course, we made another CT scan later on, but just because of time limitation, I just want to show you the angiogram at 3 years. You see here, still patent stents, but dissection in the in between the two stents, the stents in the proximal and the mid segment. So to sum up, the case of catheter-induced type A dissection, gunning class 3, complicated by occlusive spiral dissection, pericardial effusion, and perforation with stented. Other risk factors included severe hypertension, need for repeated injection, immediate stenting of the entry point, and the RCA ostium seemed to control all potentially lethal complications. Surgical correction was planned but not performed in view of the clinical and multi-slide CT scan findings that follow up. So the take-home message are as follows. This condition is usually highly lethal and should always be considered a surgical emergency. But we need to always try to immediately fix all potential complications with PCI as much as possible. And immediate stenting of the entry point may control all potentially lethal complications. We know that some patients and some people are born lucky, like the patient and myself. And meticulous attention of blood pressure control and avoidance of repeated injection during PCI is important in this kind of situation. I thank you so much for your attention.
So a fantastic case, Professor Santoso. Unfortunately, we are already running late, but this was really an amazing case. It is my pleasure now to introduce Dr. Jen Quang Lee from Taiwan. He did his master's degree at the National Taiwan University, and also got a PhD at the Institute of Biomedical Electronics and Bioinformatics, and currently is assistant professor at the National Taiwan University in Taiwan. He has several interests, and some specific interests are peripheral artery intervention as well as venous intervention. Dr. Lee, the floor is yours.
Thank you, everyone. Hi, everyone. I would like to share my slide here. Okay, so yes. So can you see the slide?
Yes, we can see the slides and hear you. Fine.
Okay, so hi everyone. So my topic today will be...
Sorry, the connection.
Yes.
Sorry, the connection of the audio is suboptimal.
Okay. How about now?
Better.
Okay, so let me start. So my topic today will be the whole arm when filters are a must, but deployment a must not. So this is the case. This is a 58-year-old woman. He had the lung cancer, the non-small cell lung cancer with brain metastasis like this. And he had progressively exertional dyspnea and short breath for 1 month. So he got the bilateral upper lung swelling and exertional facial plethora. So this is the photo for her. So the lady says that doctor, you can see my face is swelling. In my opinion is that, but I don't think you are very got the face swelling, but she insists that. And also you can see the bilateral arm is a little swelling. So this is the CT. You can see it's a SVC tumor encasement into the superior vena cava here. And this is the area here. So after the compression of the superior vena cava, so the patient got symptoms progressively. So this is the diagnostic angiography. As you can see, here is the tumor encasement. So the bilateral, whether the right side or the left side, cannot drain into the superior vena cava into the right atrium very smoothly. So we do first with the kissing stent, and we do also the post-dilatation. So this is the kissing stent. Because currently there's no stent approval for to deploy in this area, so I deploy the venous stent with the BD Venovo stent. And after the stent deployment, as you can see, there's a residual stenosis here. So I also do the kissing balloon technique here. So this is the angio after the post-dilatation like this. So this is the right side angio, and this is the left side. And also we do angiography from the lower part of the superior vena cava. As you can see, there's a slow flow with the no flow phenomenon. So thrombus you may see here, and also here, and also here. So this is the scenario after the kissing balloon. Initial after the kissing stent, there is a slow drain into the superior vena cava, but there is no flow drain into the SVC after the kissing balloon technique. So, and in this time, the patient got sudden dyspnea and agitation. The SpO2 got decreased down to 85%, and we to give the O2 mask to give he the oxygen therapy. So maybe there's some thrombus drain into the right atrium and into the pulmonary artery. So this is the initial scenario that we think is the tumor compression for the SVC here. So our idea initially is very simple, that we can put the stent, the kissing stent here, to overcome radial force from the outside of the tumor. But we should know that not only the tumor compression here, but also after the flow is diminished, then there's thrombus here, as you can see in our case. So after the stent deployment, we put the stent, but after the balloon dilatation, the thrombus initially outside the stent, then going into inside the stent. So the patient got symptoms and there's no reflow then. So what to do next? So this is our scenario. Initial, there's a thrombus and also the tumor compression here. So after the stent deployment, after the kissing balloon, then the thrombus initially outside the stent, then into inside the stent here. So what is
Dr. Lee, I have a question, because the vessel was occluded before and is occluded now.
Yes.
But in between, the patient is getting worse. So obviously there is something else going on.
Yes.
Are you now worried are you now worried to fix this thrombus component in the stent, or
Yes.
should you be worried about what is going on elsewhere?
Yes. So there's two questions here. Initially, the vessel is occluded. Even now, after the procedure, the vessel is still occluded, but the patient got symptoms. So the first thing we want to do is that maybe how to overcome the thrombus, maybe into the pulmonary artery, into the pulmonary embolism. So the anticoagulation is very important. The first thing. The second thing is to give the oxygenation therapy. And the next thing is that even the patient now is occluded, you should be aware that how to overcome. Now the thrombus is going into the stent, whether the symptoms going further into the pulmonary artery and into the pulmonary embolism is very important. So the problems now, the stent thrombosis with acute closure complicated with pulmonary embolism. Now this is the problem. So what to do next? Initially, we want to do, as you know, the pulmonary embolism, the goal therapy is to give the systemic thrombolytic therapy. And now with the progress, we can now do the catheter-directed thrombolysis. But don't forget that the patient is high bleeding risk because the patient had brain metastasis. Although there's no ICH, the history, but still we should consider that. So parenteral anticoagulation, we give it the first without the thrombolysis, the thrombolytic agent. And the other thing is that although initial is occluded and then now it's occluded, still we want to do more to open this closure. So we bail out the stent to establish the SVC flow. And then the other thing is that we want to do this bailout procedure to give outside the thrombus. So this is the rescue stent deployment. So after the two stent deployment here, you can see there's flow into the right atrium slowly, but still you can see here is a thrombus here. So we got a lot of afraid that the fear for the further pulmonary embolism. So we give the anticoagulation and into the ICU for monitor. So this is the rescue stent deployment like this. So this is an initial venoval stent, and the second two stent is the Illuminex like this, and this is the final angiography. Although there's a thrombus, but we have the flow now. After the procedure, the patient, the dyspnea and the symptom got better. So we go to the ICU for the systemic anticoagulation for 1 day. So the parenteral anticoagulation and the close monitor. After 3 days, the symptoms improve, but the swelling, the facial swelling and the bilateral arm swelling is not improved. So after 3 days, we do a second angiography. So you can see there's a thrombus with a stent total occluded for the these stents here. So now we are back to the initial scenario. That's the SAVC is total occluded, but now we have stent deployed in the SVC. So what to do next? So things in mind is that this is a huge thrombus. So stent is not feasible. Only we need to do the thrombolysis. But for the history with brain metastasis, maybe the catheter-directed thrombolysis is a good choice for this patient. But don't forget that this is a huge thrombus. After the thrombolysis, there's high risk for the pulmonary embolism. So you may want to give the SVC filter in this case. But what is the landing zone? Where is the landing zone for the SVC filter? Don't forget that. Now the further two stent, the Illuminex is deployed here, and it's only the landing zone is only here, and then it's the right entrance. So it's very difficult for this patient. So we want to do the catheter thrombolysis, but we don't have the enough zone for the landing for the SVC filter. So this is the first here. Maybe we can put the SVC filter here, but now you know that after the putting the filter, you may enangle to the stent, and then you will not be able to retrieve this filter. So what to do next? Maybe we can put the filter here, but if we put the filter here, then the SVC filter is into the right action. So you may encounter one scenario is like this. Maybe it's a dislodgement after deployment. The SVC filter will be like this into the pulmonary artery. So what to do next? So if we put the SVC filter, it may go into the pulmonary artery. So what to do next? So we try to open the SVC filter here. So you can see we open a SVC filter, but after open the SVC filter, we do not deploy the SVC filter. So this is the SVC filter, we do not deploy. So still it is connected to the hook. We do not deploy, but then we put the bilateral echoes catheter for the catheter-directed thrombolysis. So after 24 hours, is 1 day, the symptom improved like this. So you can see the thrombus resolve very beautifully. And still the SVC filter without deployment still here. So then it's in situ SVC filter successfully, then we retrieve very quickly because we do not deploy the SVC filter. Still, the hook is linked to the deployment. So this is the filter after retrieve. You can see there's a lot of thrombus inside the filter. So this is the final angiography. So we got improved SVC flow, and we put the filter smoothly and successfully retrieved it. So the patient got sustained clinical improvement. As you can see, this is a swelling phase and on, and then now it's better. So this is the take-home message. So thrombi do exist in SVC syndrome, although we always see that maybe it's only the external compression. Don't forget the poor flow going into the thrombus formation. So balloon angioplasty after a stent deployment, you should be do it very cautiously. And then this filter are mandatory for the catheter-directed thrombolysis in SVC thrombosis, because this area, a lot of thrombus after the thrombolysis, the thrombus going into the pulmonary artery very quickly because it's only very nearby. So SVC filter are applicable in this and feasible and mandatory in this scenario. The final thing is that now, if the deployment, the landing zone is not good, maybe you can open the filter, but without deployment. It's safe to use with when no good landing zone. Thank you.
So fantastic case. So we have now a few minutes for the discussion. Maybe I will start. There was also a comment from the chat. Any role for thrombectomy devices? Personally, I was thinking maybe something for Rotarex A8 French is the first question. And the second one, what is the long-term patency of this construct of 4 stents in a cancer patient with already external compression?
So the question is very good. The first thing is that even we can use the thrombectomy device, still it's very important that we cannot avoid the thrombus into the pulmonary artery. And don't forget, if we use the A French, the Rotarex, the Aspirex is still risky for the emboli into the pulmonary artery. So the filter is still very important, I think. Another thing is that also the aspirase or the rotarase is not indicated in this area. So you should do it very, very carefully. The second thing is what is the long-term patency for the SVC syndrome? In my practice, currently I have done the SVC intervention maybe for 200 cases. Most of the patients are symptom-free if we can put the stent very smoothly and with the medication, with anticoagulation, then the event is very small. Most of the event comes from the tumor progression, not from the stent, the thrombosis. This is my personal experience.
So fantastic personal experience. Really, I think a few people in the world have the same degree of experience. So this is open for discussion. Please, anybody who has some questions or? So in this particular patient, what is the follow-up? How is she doing? At what follow-up time?
Yes. So my hospital is a tertiary hospital that have a lot of patients with the lung cancer or something metastatic cancer. So most of these patients is for the symptom, not for the cure. So we discuss this with the oncologist. So after the stent deployment, we always give the medication with anticoagulation. In the past, we have only Coumadin, but nowadays we can use the NOAC to prescribe in these patients. So most of the patients are very good. So do we need to follow up with the angiography or the CT? In these patients, they always have been followed up in the oncology. They always do a lot of CT. So we don't need to do the angiography. And then the second thing is that the SVC syndrome, the SVC stenting or endovascular procedure for this patient is a bailout procedure and it's a bridging procedure. The most of the thing is the symptom, not from the stent patency.
Can I ask, is it routine now to prevent the PE in the terms of doing the stenting? So are you preferentially doing it all the time, putting a filter there now because it's so common?
Yes. So I don't think it's always to put the SVC filter as a routine practice. No, but if you put stent, then after putting the stent, now in my practice, after putting the stent, not always for the post-dilatation, I will do the angiography after the stent performance and to see the thrombus burden. If the thrombus burden is very, very large, then you don't need to give a 1-to-1 balloon, kissing balloon technique. Then the thrombus will go into a lot. Maybe you can use maybe a 60% large balloon angioplasty and then to give anticoagulation. The second thing is that even for every SVC stent procedure, I will give the pre-medication with the anticoagulation, maybe for the crescent, maybe for 2 or 3 days, then I do the procedure.
So we have a question from the chat. So maybe a participant is asking whether would have been retrospectively better to go for thrombectomy and before the second layer of stents.
Oh, stents. In my personal from the study and also doing the retrospective to research, in nowadays the SVC stenting is in little research that SVC stenting now is feasible for doing the tumor compression but what stents or what kinds of stent needs no standard procedure. Some patient will use the cover stent. Some patient now use the new generation, the venous stent. Now in our hospital, we use the venous stent with the venovo stent.
Very good. So I think if there are no other questions, in the interest of time, I would give back the word to the organizer. And again, thanking Dr. Lee for his great presentation.
Thank you.
Okay, thank you. So I would like to, so on behalf of the Hong Kong College of Cardiology, I would like to thank once again my co-moderator, Rosanna, DW, and Marco for keeping the time very well and moderating very good discussions. I would like to also thank the panelists for sharing with us their good comments and learning points. I'm sure all of you agree this is a conference with many learning points. We are going to organize our next Hong Kong Complex Cardiovascular Intervention around half year later, and hope to see you all by that time. So before we say goodbye, shall I ask all of you to turn on the video and we take a group photo? Rookie, please take a photo for us.
Yeah, sure.
With a smile, with a smile.
Thank you. Hi, 1, 2, 3, cheese. Thank you. And one more, 1, 2, 3, cheese. Thank you. Nice weekend. Thank you.
Okay, many thanks and goodbye. Thank you. See you.
Bye bye. Thank you.
Bye
Bye bye. Thank you.
Bye bye.
Thank you so much.